So, Professor Young from Rochester, Minnesota, USA. Nice to meet you here. Welcome to Ukraine.
I'm delighted to be here.
Is it your first time here?
It's my first time to Ukraine, yes.
Great, congratulations.
Thank you.
Hopefully not the last one.
I hope not.
Okay, let's start our talk. We have a lot of things to discuss. I know that you came from Mayo Clinic. It's
Yes. So
the legendary clinic. A few words about that.
It is legendary. It's in a small town, Rochester, Minnesota. Has a population of about 110,000. So it's a very small town. It was founded by the father of the Meijo brothers. His name was W.W. Meijo. And this was around 1850. He had several children, but two were boys, and he brought them up to be doctors. Just like a farmer would bring up their boys to be farmers, he brought his two boys up to be doctors. So they were giving anesthesia when they were 8, 9, 10, 12 years old.
Really?
And
impressive.
It was impressive. And he sent them both to different medical schools. One went to the University of Michigan, other went to Northwestern University.
Very clever. In this way, then they can share experience and knowledge.
Exactly. They learned different things. They brought it back. So they joined their father in Rochester. So it was a 3-doctor practice. But they were innovative. They were creative. There are still medical instruments used in surgery that are called, the Meijo forceps or the Meijo clamp, because Charlie Meijo would invent these instruments. So, but what they would do, and I think part of the secret there, their early success, they would travel and they would find the best technique to take out the thyroid gland, or the best anesthesia, or the best antisepsis, and they would bring it back to the small town in Rochester. So their success rates, surgical success rates, they were all surgeons, were fantastic. Better than the big universities in the United States. So doctors started coming from around the US to watch them operate, to see what their secrets were. And as that was occurring, more patients would come. So then they would hire more physicians. So the clinic grew and grew from this 3-person doctor clinic to be very large. By 1919, they realized that they'd created something that it should go on to the future. And they realized that if this was going to be a family business, that wouldn't happen. So they gave away all their assets to a foundation. It's called the Meijo Foundation. And in today's dollars, it would be somewhere near $1 billion they gave away to the Meijo Foundation. So it's run by a board of governors. So today at Mayo Clinic, no one with the last name of Meijo works at Mayo Clinic. It's run by a board of governors. It's a nonprofit foundation. And unlike the early days, now we have 2,800 doctors on staff, 2,700 doctors in training, and 35,000 employees, all in this small town of Rochester, Minnesota, with a population of 110,000.
Amazing. That's a great story. The most important, what I have heard for me, was that they traveled a lot, and it seems like they always came back. That's the problem for Ukraine, because a lot of Ukrainian doctors, they go away and they never come back. It's not about the Mayo Clinic, definitely. What about the principles of the clinic? Because we all know the famous Mayo Clinic principles. I know there are a lot of them, but if I would ask you just to set the 3 the most important, according to your opinion, which ones they would be?
I'll give you one.
Perfect. Instead of 3.
It's called, and this came from Wiliam Meijo, one of the sons, the needs of the patient come first. Not the needs of the doctor, not the needs of the clinic, not finances. The needs of the patient come first.
That's great. That's something that should be written down every morning by each doctor worldwide before he or she starts the day, actually, to remember this statement. Okay, so I know that you have very interesting background that actually came to medicine from biology. And when I was reading your biography, I've paid attention that actually first you came to fishery and wildlife, something like this. It was the title of your department. Isn't that correct?
Well, that's correct. In the United States, we do 4 years of undergraduate school or college, and then 4 years in medical school. So my major in college was fisheries and wildlife. I enjoy wildlife, I enjoy the outdoors, I enjoy fishing. So early on, I thought that's what I wanted to do. But then I realized I could still do that and do something that took a little bit more experience and expertise.
Okay, so you've got that we all as people, we came from the ocean and stuck in the wildlife till nowadays. Tomorrow you are going to talk about two very important topics. The first one will be about hyperprolactinemia, and the second one about adrenal gland tumors in pregnancy. Well, both topics are very impressive. Let's start from the first one. So, hyperprolactinemia. Actually, what is the role of this diagnosis in reproduction, in pregnancy and giving birth?
Yes. So, prolactin is a hormone that men and women make. We make it in our pituitary gland, which is straight behind the bridge of the nose, just in front of the ears. Pituitary gland is only about as big as your thumbnail. And in men, it weighs about 500 milligrams, in women about 600 milligrams. And it has multiple functions. We call it the master gland. So it tells our thyroid gland to make thyroid hormone, tells the adrenal glands to make cortisone, tells the gonads to make estrogen or testosterone, and tells our kidneys how to save water. So it has 4 big jobs. Now, in that, I didn't mention prolactin. Prolactin is the 5th job, and it has no function in men. Men make prolactin, but it has no function. Its main function in women is to prepare the mammary glands during pregnancy to allow breastfeeding after birth. And that's its only function in humans.
So it's like very wise wife. No one knows how strongly she can influence her husband, but she definitely does. She's ruling all the processes, but no one knows who is actually the leader. Okay, go on.
So it turns out that tumors of the prolactin cell in the pituitary are the most common type of pituitary tumor. And they're more common in women than they are in men. And when a woman develops a tumor in the pituitary that makes prolactin, it causes all sorts of problems. So if the prolactin level is high enough, it tells the breast, the mammary glands to develop, and tells the breast to release milk. So that's called galactorrhea. And when that happens, it inhibits the LH and FSH coming from the pituitary, so it doesn't tell the ovaries what to do. So a woman develops secondary amenorrhea. So the most common presentation of a prolactinoma, which is a prolactin-secreting pituitary tumor, is secondary amenorrhea and galactorrhea in women. And when that occurs, that's a sign that that woman has a pituitary tumor. It'd be very unlikely that woman would be able to get pregnant.
You know, I'm very curious, I'm very interested. Is it to diagnose hyperprolactinemia during pregnancy if it was not diagnosed before? Because actually we do not know the ranges of prolactin during this process.
Well, you're exactly right. We have very narrow ranges for men and women, women who are not pregnant. But once a woman becomes pregnant, part of what's happening through pregnancy is getting the breast ready for breastfeeding. So prolactin levels go up in pregnancy, but the reference range is quite wide. In general, we don't advocate measuring prolactin during pregnancy. The most common reason to measure prolactin is either that woman with secondary amenorrhea and galactorrhea, or a woman who's interested in fertility and is having difficulty getting pregnant. One of the questions should be, could she have a pituitary tumor making prolactin? But during pregnancy itself, usually we would not measure prolactin because the reference range is so wide.
What would be your advice for women with microadenoma? If we definitely know that she has it, all of us understand that it could be related to miscarriage, according to certain statistics, and we know that it could be related to certain changes in visual fields. That's something we definitely have to take care about. But what else?
Right.
We have a lot of such women.
So women that have prolactin-secreting pituitary tumors, they're either microadenomas, which is 10 millimeters in diameter or less, or they're macroadenomas, which is more than 10 millimeters in diameter. If it's a microadenoma, Basically, usually these women will have been treated with a dopamine agonist, cabergoline or bromocriptine, that brings their prolactin down and allows them to get pregnant. As soon as they know they're pregnant, we stop the dopamine agonist, bromocriptine or cabergoline. So we stop it. And then we don't monitor prolactin. If it's a microadenoma before conception, it will not become large enough to cause any problem during pregnancy. So we don't check visual fields and we don't check prolactin levels. But if it's a macroadenoma that was treated before pregnancy and now we've stopped the dopamine agonist, that has the risk of growing and causing problems. So in those women, we check visual fields each trimester. And if they develop visual field defects, we put them back on a dopamine agonist like bromocriptine or cabergoline. In the microadenoma women who made it through pregnancy, if they want to breastfeed, we allow them to breastfeed. In the macroadenoma patients who develop visual field defects, we counsel them that it probably isn't a good idea to breastfeed.
If we consider such, let's say, problematic pregnancy as a window for the future health of a woman, what we have to be aware of?
That's a good question. So in that woman who had a prolactinoma, delivered a healthy baby child, that tumor's still there. And if she wants to become pregnant again, she'll need to be on a dopamine agonist. And the same issues will arise. Now, if there's a long gap between pregnancies, sometimes we actually can cure, basically destroy, the prolactin secreting pituitary tumor with our medical therapy. So there's this apoptosis rate of the tumor that's maybe 10, 15%, that if they're on a dopamine agonist for more than 2 years with very low prolactin, that tumor may be destroyed. And therefore, when they want to become pregnant again, they don't have to worry about prolactin.
What about duration of lactation in these women? Because, you know, nowadays we have a lot of, let's say, fashion type of breastfeeding up to 3 years, whatever. Any obstacles in case of problems with prolactin?
So everything I've said so far about allowing the woman with a microadenoma to breastfeed is assuming that breastfeeding is going to go for 1 year, year and a half, 2 years. Beyond that, I would be worried that microadenoma has had an opportunity over 2 or 3 years to get large. So I'd be concerned. And in those women, I would start doing visual field exams.
What, let's say, criteria could be set for recommending an operative treatment for a young woman in reproductive age?
Right. So before 1981, we had no medical therapy for prolactinomas. They were all operated. And the problem with operating all women with prolactinomas is there's a variable degree of hypopituitarism. So LH and FSH are not made regularly. And then patient has secondary amenorrhea. The chance of pregnancy is extremely low. So in a woman who's seeking fertility, there's no question. The best single treatment is a dopamine agonist, cabergoline or bromocriptine. But there are a subset of those women that can't take it. They can't take it because, for example, cabergoline could cause psychosis. Or sometimes the pituitary tumor is resistant to the dopamine agonist. In other words, you give them cabergoline or bromocriptine, but the prolactin level stays high and the tumor doesn't shrink. So when a woman does not tolerate it, for whatever reason, the medical therapy, or if the tumor is resistant, those are the two reasons to consider pituitary surgery.
Thank you so much. One more very practical question. If, for example, in preconception, we have a patient and she has sky-high prolactin, we gave her treatment. We were very lucky, and she in particular was very lucky to get pregnant. And we see, for example, at the end of the first trimester that her visual fields are, let's say, narrowed.
Yes.
And we think about prescribing her dopamine agonist, but still, for example, not 12, let it be 9 to 10 weeks of pregnancy. So meaning that first trimester. What is your attitude towards that?
This is a good question. It's a tough issue. Obviously, we like to avoid all drugs during the first trimester if possible. However, if the mother's losing vision, we think the risk of bromocriptine is lower than a pituitary operation. So even in the first trimester, we would use bromocriptine.
Thank you so much. Very important question. Okay, let's move to the second part of our talk. It will be regarding adrenal gland tumors in pregnancy. It's not so common, I would say, in our, let's say, daily practice, but maybe I'm wrong. Maybe it's underdiagnosed and we do not know much about diagnosis of these problems. What is your opinion? Is this problem, let's say, diagnosed well worldwide, or still we have some hidden prevalence?
Great question. So the three types of functioning adrenal tumors I'd like to address in pregnancy is pheochromocytoma, Cushing's syndrome, and primary aldosteronism. I think we're doing okay with pheochromocytoma and Cushing's syndrome. Where we have a problem worldwide is primary aldosteronism. It affects 1 out of 20 people with high blood pressure, and that includes women in the reproductive years. Women who are in the reproductive years, when they want to get pregnant, my contention is they all should be tested, if they have hypertension, they all should be tested for primary aldosteronism. It's so easy to do. A morning blood test, measure aldosterone and renin. That's all the obstetrician gynecologist needs to do. What's happening though, and now if we just think about not the women who are seeking pregnancy, but all people with high blood pressure, it's so underdiagnosed in the United States and across the world. And if you don't diagnose primary aldosteronism, it leads to cardiac failure and renal failure. So it's really important early on, when someone's diagnosed with high blood pressure, they all should be tested at least once for primary aldosteronism. And it's so easy to do. Most doctors out there think it's complicated. It's one of those crazy endocrinology diagnoses that takes a lot of tests and it's really complicated. It's not. It's simple. Morning blood test, measure aldosterone and renin. So in the setting of a woman seeking fertility who's hypertensive, I think that should be done. The other thing, if a woman has a genetic syndrome that predisposes to pheochromocytoma, what do I mean by that? Multiple endocrine neoplasia type 2, neurofibromatosis type 1, von Hippel-Lindau syndrome. If a woman has one of those known syndromes where 50% of people will develop a pheo, boy, I want to know about that before she gets pregnant. One of the worst things I try to manage is the woman who's pregnant has a pheochromocytoma. It's a bad combination. The mother's life is at risk. The fetus life is at risk. So it's important to diagnose it pre-pregnancy and resect it pre-pregnancy so it's not a problem. Cushing's syndrome is rare, and I don't have any special comments on screening for Cushing's pre-pregnancy. As you know, with Cushing's syndrome, very frequently women get secondary amenorrhea, and so they actually don't get pregnant very often. The subset of patients with Cushing's that get pregnant are those that have a benign adrenal adenoma that's making pure cortisol, but not too high. If it's too high, then they'll have secondary amenorrhea.
Two questions stuck to my mind during your great explanation. So the first one was regarding the blood test for renin and aldosterone. So it's a morning blood, correct? Do we need any particular preparations for that? Like 3 days no sex, 5 days no stress, 7 days of good sleep, whatever, because that's the main problem, especially in Ukraine, especially among obstetricians, that we say, well, it's so hard to find a good laboratory, well, it's so difficult to make correct test because during the day these hormones are being changed so many times and you never get into a correct range, whatever. I think it's not only the Ukrainian problem. So, do we need any particular preparations for that?
Fantastic question. And I think part of the reason we have this vast underdiagnosis of this disorder across the world, I think endocrinologists like me are to blame. Endocrinologists are the ones that made all these rules. Oh, you can't be on blood pressure medicines, you have to be on a sodium balanced diet, all these rules. It turns out we don't need these rules. We don't need these rules. And I just published a paper last month that documents this. It's because what's happened is created barriers. Because doctors say, well, my patient's blood pressure is 170 over 110. I can't stop blood pressure medicines. That puts the patient at risk for stroke. And they're right. They shouldn't stop blood pressure medicines. They should test. It's simple. Morning blood test for aldosterone and renin. Turns out most blood pressure medicines do not affect this measurement. Most sodium diets do not affect this measurement. What does affect is the time of day. You can miss this diagnosis if you measure aldosterone and renin in the afternoon. So that's why it needs to be a morning blood test.
Okay, and what is definitely we'll talk about that tomorrow, but for those who were not so lucky to visit our conference, just a few words about the treatment of primary hyperaldosteronism.
So
the state of the art.
Yeah, the treatment of primary aldosteronism in a non-pregnant adult is pretty straightforward. We determine, once we've made the diagnosis, we determine if they have one adrenal disease, which is usually a benign aldosterone-producing adenoma, or two adrenal disease, which is bilateral hyperplasia. If it's one adrenal disease, we offer those patients laparoscopic adrenalectomy. They're in the hospital one night, they're back to work in 7 to 10 days, their hypertension's cured. It's like a miracle. Now, if they have bilateral hyperplasia, we don't think taking out both adrenal glands is a good trade, because then they have to go on hydrocortisone and an aldosterone pill, fludrocortisone, every day. So for those patients, we don't operate. We use a drug that blocks the aldosterone receptor, and that's either spironolactone or pleuronone. And they have to be used at the correct dosage. If used at the correct dosage, it's a very good treatment. So that's in the non-pregnant adults. In women who are pregnant, the reason I want to avoid this is it can be a catastrophe in pregnancy. It turns out that some of these aldosterone-producing adenomas actually have these ectopic receptors for HCG. And as you know, HCG levels are very high in pregnancy. So these ectopic receptors that are on these aldosterone-producing adenomas, when HCG goes up, it stimulates the adenoma to make more aldosterone. So it can be a woman who has stage 1 hypertension, 1-drug hypertension, and then she gets pregnant and she goes to 4-drug hypertension and hypokalemia because HCG is high, telling that aldosterone-producing tumor to make more aldosterone. So that's something we want to avoid. We want to avoid adrenal surgery in pregnancy if possible. Sometimes we're pushed into doing a laparoscopic adrenalectomy in pregnancy just because we cannot control the aldosteronism, the degree of disease.
That's clear. So at the end of the day, just few tips regarding the hidden prevalence. So if you see that woman has hypertension, if she has secondary amenorrhea, if she has certain particular features of her appearance, and if you don't know what's going on, just check her adrenal glands.
Yes.
Is that correct?
Absolutely.
Something else?
Nope, that's perfect.
It was a pleasure.
Yes.
So, Professor Young, professor who is breaking the rules.